Today we're going to talk about the patient that presents with a CHF exacerbation. How do you know when to intervene with Lasix, nitro, BiPAP, or other more aggressive therapies? This will build on our prior lecture on the approach to the patient with shortness of breath. So now that we're ready, let's go ahead and begin. So like we did before, the first thing that you need to do is develop your critical differential diagnosis. In this case, that'll be pneumonia, pneumothorax, PE, asthma, COPD, and CHF exacerbation. We'll assume that you've already figured out that this patient is in a CHF exacerbation. Maybe when you assessed the patient, you noted that they had JVD, crackles at the bases of their lungs, lower extremity edema and swelling. Maybe the patient told you that they had dyspnea on exertion and PND. Or maybe you went a step further and used the ultrasound to determine that the patient had a poor EF as well as a dilated IVC. But in either case, you've been called to a patient who's in some form of respiratory distress secondary to a CHF exacerbation. Like we talked about in our prior lecture on shortness of breath, the first thing that you need to do is go to the bedside and determine what degree of respiratory distress your patient is in. This is a spectrum where your patient can be in 3 different categories: mild, moderate, or severe respiratory distress. So how do you determine where on your spectrum your patient is? Understanding full well that they may not just be in hard, mild, moderate, or severe, but rather could be in mild to moderate or moderate to severe respiratory distress. What clues are you going to use to further figure out what degree of respiratory distress your patient is in? So the first thing to do is to just look at your patient. What's their respiratory rate? What's their SaO2? Are they using any accessory muscles or having retractions? How many words can they speak in a sentence? So since there is no hard criteria and your patients can actually fall in mild to moderate or moderate to severe respiratory distress, figuring out where on the spectrum your patient falls will take some clinical experience and will become more and more apparent as you see more and more patients with shortness of breath. The reason why we're spending so much time talking about what degree of respiratory distress your patient is in is because it'll help guide what your initial steps will be when you start to resuscitate this patient. So before we move on to the specific interventions that you'll perform on your patient, let's just go over a little physiology. Based on the Frank-Starling's curve, we know that EF is a function of preload. Patients with the optimal preload will have maximum EF because this is where there is maximal overlap of your actin-myosin complexes. As the preload exceeds this optimal amount, the EF will actually decline as the actin and myosin will have worsening overlap. With this information, we can now look at the circulatory system and apply some of these concepts. The circuit looks as follows. You have the right heart, which pumps blood to the lungs, which then goes back to the left heart, which goes to the kidneys, and back to the right heart. When you have too much preload, let's say you're at this part of your curve, your EF will be compromised, and as a result, there'll be less blood that goes to your kidneys. As a result, your kidneys will think that they're hypoperfused and will activate the RAS system, the renin-angiotensin system. This will lead to further retention of fluid, and as a result will worsen your preload, thus creating a vicious cycle. Now that we understand these principles, we can attack this patient by first focusing on improving the preload. By doing this, we'll drive the patient back to the optimal preload, which will improve the EF, improving perfusion of the kidneys, as a result, knocking out the RAS system. The medications we use for preload reduction are Lasix and nitroglycerin. Nitro also has the added benefit that it's an afterload reducer as well, when used in higher doses. Now remember, this is just a primer, so all we're trying to do is arm you with the initial resuscitation tools. There are other ways to attack the preload and afterload. Also, one other caveat is you wouldn't want to use these interventions on a patient who is preload dependent. Examples of that would be a patient with severe AS or pulmonary hypertension. Okay, so now that we have all that out of the way, let's get to the fun stuff, which is actually treating the patient. Remember, the first thing you're going to do is look at your patient and figure out what degree of respiratory distress they're in. Are they in mild, moderate, or severe respiratory distress? As a review, you'll be figuring out where on the spectrum your patient is by looking at their respiratory rate, their oxygen saturation, whether or not they're using accessory muscles or are having retractions, and how many words they're able to speak in a sentence. So if you look at your patient and determine that they're in mild respiratory distress, you may want to start by giving them some Lasix to begin the preload reduction. If they're in moderate respiratory distress, you may want to give them Lasix and also add in nitro. Now here's the important part. If your patient is starting to tip over into moderate to severe respiratory distress, you should start BiPAP. Don't wait until your patient is in severe respiratory distress because at that point you'll be too late. CHF exacerbation can be a rapidly reversible condition, so by temporizing your patient with BiPAP, you can turn them around and get them back to the mild to moderate range. If the patient is in severe respiratory distress, go ahead and convert these medications to drips and intubate your patient. If your patient is also hypotensive secondary to cardiogenic shock, you may need to start them on a pressor, such as norepinephrine. Again, figuring out what degree of respiratory distress your patient is in is so important because this will guide your initial resuscitation. If you're a mnemonic person, you can use the mnemonic unload me to figure out what interventions you should perform on your patient who's in moderate to severe or severe respiratory distress from CHF exacerbation. So let's fill this out. U is for upright, N is for nitro, L is for Lasix, O is for oxygen, which means BiPAP or intubate the patient, A is for an ACE or an ARB, D is for digoxin, M is for morphine, and E is for electricity in case you need to cardiovert your patient. So while you're resuscitating your patient, you'll also want to be ordering labs and imaging so that you can further work up what's going on. To figure out what to order, we're going to need to look at our differential diagnosis again. So remember, for shortness of breath, that includes pneumonia, pneumothorax, PE, COPD, asthma, and CHF exacerbation. So with this, we can figure out what labs to order. We'll probably want to get a CBC to make sure the patient isn't anemic, a basic metabolic panel to see how the electrolytes are, as well as to ensure that the patient isn't going into cardiorenal syndrome. You'll want to order an EKG to see what rhythm your patient is in case you need to cardiovert them, as well as a troponin. So a lot of people ask why we order the troponin, and the reason why is because the troponin is a marker of mortality. CHF exacerbation patients with elevated troponins have an increased mortality and as a result need to be more aggressively diuresed. You can also order a BNP. And finally, plus or minus a D-dimer if you're concerned about a PE. For imaging, you'll probably want to order a chest x-ray to ensure that your patient isn't having a pneumonia or a pneumothorax. The last thing that we're going to go over is the New York Heart Association classification system for CHF exacerbation. This is important because it can help determine what your disposition of the patient will be. The classification system goes from class 1 to class 4. Class 1 are patients who are minimally symptomatic. Class 4 are patients who are hypoxic at rest or symptomatic at rest. Class 3 are patients who become symptomatic with minimal exertion. So usually I ask the patient if they can make it to the bathroom before becoming short of breath. And finally, Class 2 is somewhere in between Class 1 and Class 3. So with regards to your disposition, typically Class 1 and 2 can be disposed home. Class 4 will be admitted. And then Class 3 is generally admitted unless you can get them to Class 2, in which case they can be discharged home. So this is our primer on CHF exacerbation. This is a really big topic, but all we're trying to do is give you the big boxes that you can then fill in and to help kind of organize your thoughts on this topic. Thanks for watching.